sure you're like writing it down somewhere, asking questions, like keep those questions because I will at some point answer them, even if we don't have time today. Like you can always DM me and we will chat, we will set up a one-on-one, like all of that good stuff. So I am Zoe Luzak. I'm currently based in Boston, Massachusetts, and I'll go over a little bit more of my background in just a second. But I really wanted this presentation to be focused on becoming the kind of human that the world needs, especially right now. So let's go ahead and dive into it. So, medicine is a moral enterprise. And this is a quote by the late Dr. Edmund Pellegrino, who is one of my inspirations. He had this white coat ceremony presentation that he would give every year. And it was called the virtuous physician. And it's that physician that every doctor should try to aim for. And that's kind of what my goal in pursuing this path has been. So some of my origin story as a first generation college student, a non-traditional pre-med. I'm currently aspiring to MD PhD program. So I'm applying this cycle like right now. It's a little scary. I'm going to be completely honest. My path has been very interdisciplinary. There has not been, I would say, like a single linear aspect of it. I've kind of just let it flow and grow as I discover new things or find new topics to talk about, find new classes to take. I'm currently working on NIH Recover, which is the National Institutes of Health's long COVID study. So it's a really large study based in the United States. And we're researching long COVID and what that looks like in the population. And then I'm also a part-time student, an M.D.s student, which is a master's in bioethics at Harvard Medical School. I absolutely love that. So I will talk more about that. And then I'm also an amateur content creator. I started grad school tips while I was working at a graduate school, and I realized a lot of students were getting into debt and I didn't like it. It felt icky. And usually when something feels icky to me, there's kind of a way that we can solve some of those issues. Not necessarily a perfect solution in place yet, but we're working on it. So who am I? This is a photo of me walking my dog and my cat. I don't know why my parents let me do that, but they did. And this is my current self in front of the kind of quintessential Harvard Medical School wall. So as a teen, I really enjoyed advocacy work. I got involved in anti-tobacco campaigns and I helped pass some of the legislation in Virginia because Virginia is a big tobacco state. And so I kind of wanted to change what that looked like. And we did. We passed that legislation, made all schools in Virginia 100% tobacco free. And I think that was my first taste in public health because a lot of times we equate public health with, okay, vaccine mandates. We equate it with the common good. But sometimes it can just be advocacy and talking about something that you are passionate about and maybe has directly affected you. For me, I had a lot of family members that had smoked, and a lot of them ended up dying of COPD, heart disease, things like that, that were definitely preventable deaths. But I saw that firsthand, and it kind of lit that fire for me. No pun intended. And then I went to the University of Virginia for undergrad. I did not get into my number one major because at UVA, you had to apply into majors, which is kind of rude because I had already gotten into the school. So why couldn't I just go into my major? But it ended up making some of the majors very competitive, including global public health, which is what I thought I wanted to do. So when I got that big fat rejection, I was like, what do I do next? And cognitive neuroscience seemed kind of cool. So that's what I ended up doing. And then I ended up finding some random bioethics classes that would fulfill some of my requirements. And I ended up loving bioethics so much that I started minoring in it. And then after graduation, I went and worked for a company called Rescue Agency, where they did a lot of the behavior change marketing related to public health campaigns. I really, really liked it, but it was a little, I don't want to say boring, but I didn't get that patient clinical interaction that I kind of wanted. And that's when I realized that I needed something a little bit more than just public health alone. I wanted to really see the human condition. And that's when I started to pursue some pre-med prereqs, because while I was at UVA, cognitive neuroscience, we took a lot of psych classes. We were kind of in a little bit of neuroscience classes, but mostly like those more so non-basic sciences or the social sciences. Um, so at the same time as I was pursuing some of these prereqs, I started volunteering in the clinical realm. I started working at Georgetown University, and I was working in their graduate school. And this is where I started seeing students get into debt because they wanted to go to medical school, but they also wanted to pursue global health or infectious disease. So I was watching them rack up hundreds of thousands of dollars in debt. And it was kind of scary for me because I was the one that was helping them fill out their FAFSAs. And at the same time, I was trying to help the university enroll more students, and I felt like I was in this dilemma. So that's when I started posting online. And I wanted students to realize that there are scholarship options out there, that there is a really cool program that a lot of universities offer, and it's called the Tuition Assistance Program. I kind of think of it like your health insurance or like your dental insurance. So when you get a job and you get this insurance involved in the US especially, but the schools have an incentive for you to stay there. So they want you to keep working for them, but they also want to help you in any way. So they allow their employees to enroll in classes. But most of the time, they end up paying your tuition. So at Georgetown, for example, they would pay 90% of my tuition if I was in a program there. Harvard, 90% of your tuition gets paid if you, at most of the schools in Harvard, if you work for them. UPenn, for example, 100% tuition reimbursement. And so today I'm working with NIH Recover, but I'm NYU. So NYU actually helps pay for my tuition at Harvard. So that is something that I really want you guys to just think about in the future. It is hard to work full time while also going to school. I'm not going to lie to you. It's definitely a tougher scene out there, but it's really cool because I see a lot of crossover in my schoolwork and my work, and I'm able to get the two to mix. And that's always what I think about when I'm doing a project for school. How can I also apply this into my work? So that's where a lot of my baby research comes into play. So at work, I'm currently writing a paper related to the ethics of using AI to make plain language summaries of manuscripts. So what I do right now is I put in these really jargon-filled manuscripts that have a lot of technical terms, and I put them into AI and I get them to make a summary of that manuscript at a 6th grade reading level. So that is kind of it seems a little bit of a basic concept, but that's kind of novel in the science realm. Not a lot of people are doing that to make their research easy to digest and translatable. So that's just one little way that I've been applying my work and my schoolwork into my personal research too. And then I'm also able to create content around it. And that's where some of my inspiration comes from. My TikTok and my Instagram is how can I communicate with the world and kind of show myself and be my silly, goofy me, while also making sure that it's educational content, making sure that someone gets something out of these videos. So location wise, I grew up in Virginia. I then moved to DC, and then now I'm here in Boston. So that was a very long introduction. I apologize for that, but it kind of gets us to this next point, or not. I'm definitely skipping slides, you know. I wanted to give a little bit more about like who I really am. This is not going to let me go, is it? No, sorry, y'all. I'm being technologically. There we go. Okay. So who I really am. This is me. I'm a real human. I'm not a robot. Sometimes I don't love looking at my resume because it feels a little bit too dry. I feel like you don't really get a full sense of who I am. I love being in front of the camera and talking to people and just getting to know the world that way. I have dogs. I ride courses. I go on runs. I'm a big iced coffee girl. I could probably drink like gallons of iced coffee. I could get hooked up to an iced coffee IB. I recently got to present some of my research in Saudi Arabia, and that was really fun because I got to see a completely different perspective related to my research, which is very social sciencey and applying abstract normative frameworks into everyday life. And sometimes my frameworks are very American centric. So trying to apply them into other cultures in other parts of the world, it doesn't work out as well. But you need to have those discussions and that feedback loop. And that's some of the stuff that I've really realized is being able to travel and experience different cultures and interact with other people who share different values than you. But in the end, we're all connected because we're all human and we're all going to try to strive for somewhat of the same thing in life, which I would argue, as Aristotle would, is happiness. Okay, so in going to our next slide, maybe if I can, sorry, y'all, again, first time kind of doing this. Okay, so finding my way. Let's talk about bioethics now. This is where I get really excited. So bioethics is kind of a unique field. And the reason that I personally love it is you guys can clearly see I'm a chatty Cathy. I love to yap. So it kind of is like the moral storytelling in medicine. And having this idea of morality, when we think about morality, it's a very polysemic term. You can't really confine it to one field or one area. It's very interdisciplinary. You can look at morality and ethics in the law, in medicine, in media, in every aspect of your life. And what I really, really like about bioethics is that there's no clear answer. So you can't really just check a box and say, okay, that's the answer. And I think a lot of times it brings out this humanistic approach to a very sterile field. And when I first came into bioethics, I would get so giddy and excited when I would find the objective answer. And I remember going into a clinical ethics case and I said, I think this is it. This is the answer. Like it's clear cut. And I would get so excited that I had this objectivity to it. I brought the evidence to the case. I was ready to make a clear answer. And then as I've learned and as I've kind of trained more into this field, there really is never going to be a clear answer. And we're going to get to that in just a second. So to give you an intro to what bioethics is, I wanted to give you guys a little bit of a case. I'm going to play 2 clips. There was a cuss word in the middle, so we're going to play it into 2 because I just want to be a good presenter today. But I'm hopeful that you all can hear this sound. So to preface this, these 2 individuals are talking about their one friend's cancer diagnosis. The guy on the right has a cancer diagnosis, and his friend is trying to ask him, okay, how bad is this going to be?
It's not a picture of anything. Well, you're going to be okay. I think. What are your odds? I don't know. I mean, I looked it up and it said 50-50, but that's like the internet. So it's not that bad. It's better than.
So next we'll go to the next part. So keep that in mind, okay? It's not that bad. 50-50.
Yeah. Fine. 50-50. If you were a casino game, you'd have the best bets. Yeah. Thanks. Okay.
So when we think about these percentages and what that really means in making decisions, you really have to think about what is this true value of numbers? Is more information inherently better? And at what point, who should be making these decisions? So I always think that's a fun way to kind of bring up bioethics and what it really is. Because as I said earlier, it's an interdisciplinary field. It's broad. And so I want to bring up this case of the ethics of prenatal genetic testing. This is actually one of my professors. So when she was pregnant at age 40, she had a routine screening test reveal that her child had 1 in 40 chance of having Down syndrome. So imagine a 1 in 40 chance if you're winning the lottery. That sounds pretty good, right? Like, yeah, I'm buying that lottery ticket. Or imagine you're boarding a flight and there's a 1 in 40 chance that the plane will crash. That is a pretty high risk there, right? So these numbers are so unique in the sense that can we really place value on them? Or does the value come from the context and the personal influence that that decision is going to have on your life? And so that's something that I've learned a lot in bioethics is you can look at something through your own lens, but there's always going to be another lens to look at it. And I think that's one of the coolest parts about this field. And something that I really liked that I wanted to include here is she discusses, and in a pregnancy, you're making them the decision under time pressure about the most precious thing in your life. And you think about a lot of the things in medicine. When you see those episodes of Grey's Anatomy and you see the family members crying and sobbing, and the doctors at times seem so objective and they seem like they are making just, no, this is what's happening. This is what we have to do. You have to keep in mind that that family member's mom or dad or sibling or husband. Like that is that person's person. And sometimes I think we forget about that when we're trying to bring out this objectivity within a very sterile field. So exploring bioethics and clinical ethics. So this is kind of where I want to actually define what is bioethics. So bioethics is ethics of medical and biological research. And that's the very cut and dry way to put it. But you can also see from some of these previous examples, bioethics really has a very robust interdisciplinary approach to life. My main focus is on something called clinical ethics. So my goal is to offer recommendations and guidance to a requesting party. So this can be a clinician, this can be a nurse, this can be a patient, a family member. Anytime someone within a hospital setting has a morally distressing case, they can consult an ethics team. I know in the United States, part of the accreditation for the hospital accreditation process is that they must have some type of ethics. So a lot of times this ethics is defined as an ethics committee. The way that committees are structured, though, looks very different depending on the hospital system. I have been on ethics committees where it's a single person that then rotates throughout 24-hour shifts, and they are made available for anyone that needs them during those 24 hours. I've been on other ethics committees where it's a committee of 3 to 4 individuals, and they deliberate on any type of ethical issues. Then I've also been on other ethics committees where it's literally 50 people in a room and everyone is trying to bring in their perspective in their case. Each one has value. There are some that I've noticed that are a little bit better than others when it comes to offering recommendations and decisions. I prefer more of a smaller committee style, but it really just, again, depends on the context. But the real goal of an ethicist is to be a neutral player, to be that person that kind of comes in and can offer kind of a guide. And the goal of an ethicist is to not be the final decision maker, nor to play God. I know that this is sometimes the perception of an ethicist is they come in and they're holier than thou and they are kind of in to make these decisions, and that's really not the case. The goal of the ethicist is to offer these recommendations, and the individual that has created the consult request can either follow them or reject them. And so how does it fit into medicine and public health as a whole? A lot of it is overlapping. We see medicine, morality, and human flourishing kind of being interconnected. And we see individuals wanting to have these different aspects because in reality, if you are in medicine and you are morally distressed the entire time, I can guarantee you that's going to lead to burnout and not the best career, right? So the goal is to reduce any type of moral distress for the physician, but a lot of times we have to reduce that moral distress on the patients and their family. So it ends up being kind of this life cycle. And ideally, if people were not put in some of these positions, which can be saved through a lot of the public health realm, they wouldn't we wouldn't be seeing this distress to start with, right? So again, we see it very much interconnected, and you can kind of look at it like a circle. So I wanted to go over a clinical ethics case study with y'all because I think that's the best way to really understand what clinical ethics is. So let's talk about Miss Smith. Miss Smith is a terminally ill patient with metastatic lung cancer. She is admitted inpatient for palliative care due to severe pain. Health providers grapple with an ethical dilemma: how to balance aggressive pain management with the potential to hasten death through a continuous IV morphine infusion titrated to Miss Smith's pain level. Medical interventions may unintentionally hasten her death. And so, in thinking about this, we see Miss Smith, who is already, I didn't add this in here, but she's already on hospice and palliative care. So she's nearing the end of her life, but the physicians fear that if they give her too much morphine, that is going to inadvertently kill her. And remember, the goal of the physician is to do no harm. So at this point, what are we thinking? How do we feel as the physician in this case? And I should also note that the physician is the one who is requesting the ethics consult. So let's go ahead and put in the chat some of our thoughts. Oh, I see some hands raised. Okay. I am gonna unmute Adam.
Hi, is my voice clear?
Yep.
Okay, so usually the doctor will often present the case toward the patient themselves and tell them, okay, you have two options here. However, in the case that let's say the patient wasn't capable of deciding and like they asked for my recommendation, I'll try to find an equilibrium and where they aren't in like any major pain. However, the morphine isn't too much. Sure, it will hasten their death to some degree. However, it's not going to like kill them immediately. Just try to find like an equilibrium between both.
Yeah, I really like that. And I think so maybe that's when we give the recommendation, okay, instead of continuous IV morphine, maybe we do dosed IV morphine, and we do a check-in every 30 minutes to an hour, maybe.
Maybe even different forms of drugs. And like, let's say every 2 weeks, we alternate between, let's say, morphine and other forms of like pain relievers, just so like their body doesn't get acclimated and we can like maintain a lower dose.
Yeah, I really like that. Okay, let's go to the next one. I think you pronounce your name Ashita. I might be
Yeah.
wrong.
Yeah. I
Perfect.
was also thinking it's important to ask the patient themselves what they want to do because a lot of times maybe they don't want any more medical intervention since they're on palliative care and what their family thinks is best for them.
Yeah, no, exactly. And I think at this point, I honestly, this case is a little bit, this was a real case. Names have been changed, but Miss Smith, I want to say, might have been in a coma at this point. So she was unable to communicate, but her family members, who were her healthcare proxy, were very close to her, and they felt like they could embody her wishes. But I really like that, because I think bringing in the family perspective, like ideally these people know her very well, and they should be able to offer kind of that, not necessarily the decisions on her behalf fully, but kind of embody those decisions, right? Okay, I think I think that was great. Let me just check the chat. What about factors like insurance policies for specific drugs? How would they impact the physician's ability in an ethical dilemma? That's a really great question. I think one of the things that we talk about in bioethics a lot is, how do we make sure that we are being effective in our treatments? Essentially, do we have to take into account aspects of the hospital system? Sometimes we see this when we have allocation of resources. And a lot of times when physicians are in these situations, they're not necessarily thinking about the insurance policies for specific drugs, or if this patient is covered under an insurance plan. And I do think even now it's becoming a little bit scarier. I don't know if anyone follows the Elizabeth Potter case that has been happening with the United Healthcare. It's become very popular on TikTok and on Instagram because she is very much being an advocate for physicians and trying to get coverage of certain coding. And something interesting that I think a lot of pre-meds should realize is how some of these codings of specific procedures and drugs come about. And it's actually through the Centers for Medicaid and Medicare. They're the ones that create these codes that then ensure that certain treatments are covered. So they have these little like 3-letter codes that come in, or actually they're probably more than 3 letters now, but they have these little codes that come in, and each procedure, each drug, each intervention is coded under that, but they're the ones that kind of set the standard. So if we need a new standard, we kind of have to go to them. Okay. I think it is up to the patient if they are lucid enough. Also, quality of life should be a factor here. No one wants to live in pain, and I'm sure that some people would rather live a shorter life in peace than a longer time in pain. I really like that sentiment, because that is actually something that I'm doing a lot of research on too, is how can I increase the quality of life rather than the quantity of life? And it's this idea of health span, which is as we age, how can we promote that quality? How can we promote that health span rather than lifespan? So I definitely agree with that one. And then doctors should slow down the morphine injections just so the possible speed up of death doesn't occur, but also ask the patient and her family members to make the final decision, because maybe they don't want her to suffer anymore and would rather increase the morphine injections. I really like that sentiment too. I think this is definitely a case where we should try to consult with the family and see what they would want for Miss Smith, and what would Miss Smith want here. What if the person is unconscious and in pain and they don't have anyone to decide for them the treatment or course of action? That is a really great question. So I think some of you all know the term DNR, do not resuscitate, right? So DNR is usually facilitated under something called your living will, or you can also call it an advance directive, depending on what state you live in. They look a little bit different. They're named different things, but they all essentially kind of have this guide for how you would want to be treated in a case of an emergency, and in case of being unconscious, or in excruciating pain that you are not able to make decisions. We call this lacking decision-making capacity. Most of the time, a psychiatrist will come in and declare, or a neurologist sometimes, and depending on what hospital system you're in, it can differ. But someone may come in and say, okay, this person is lacking decision-making capacity. What can we do? Who can make decisions for them? At that point, if we don't have any family members, we don't have any type of documentation, let's say it's a kind of freak emergency, ideally the standard of care, and the doctor being the person that is trying to do no harm, is going to make the decisions. That can be a little bit paternalistic at times, and that's where sometimes we see a little bit of gray area. But sometimes people have these advanced directives, and they can help guide these decision-making, this decision-making capacity. The thing, though, with advanced directives is a lot of times they can get out of date. So let's say I created an advanced directive 10 years ago. That means I would have been 16. I can guarantee you my lifestyle when I was 16 is a lot different than me being 26 now. So maybe my decisions or my ideas about myself and what I would want would look a lot different. So that's just something to keep in mind. And it's also something to really just think about when you guys are doing your everyday lives. I actually, this is a little weird, being a 26-year-old, or weird in the general sense, but I have these conversations with some of my close friends because I realized I want them to know what I would want, which, guys, for everyone on this call, I want every measure done. I want you to scan me. I want everything. I want an fMRI if they think that I'm brain dead. Like, I want everything. But I've had these conversations so openly and actively with my friends and family members that I do think that they can embody what I would want in an emergency situation. And sometimes it's hard to talk about death like this. I'm going to keep trying to go through some of these and make sure that I'm not taking too much time. Okay. I think Ms. Smith's and her family's consent is pivotal and matters the most. Other than that, I believe the physician should try to regulate the dosage or find better alternatives if there are any. Some patients don't want to be drugged up before they pass because their brain gets so foggy, but I understand if they also don't want to live in pain. Correct. Yes. I have mixed feelings about this. Exactly. I want to emphasize that the mixed feelings come in so often within clinical ethics. And getting back to kind of one of those first stories that I talked about, I always felt so good at the beginning when I could be objective and I didn't let my feelings come in. But now that I'm in this, I let my feelings and my experience come in because I want to show, I want people to know that I am a human and I can recognize what they're going through. Maybe I've never been through that, but I've seen patients in similar situations and I've seen how family members try to navigate this and deal with this. Though some family members are intolerant and want a quick death for life insurance purposes, I think every case is unique. Yes, 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 yes. And I think that's something that I really would like to emphasize here too, is that context. It's such, each case is going to bring its own unique features, its own unique patients, dynamics. And we can't make those personal decisions for everyone or anyone. We can help guide them and we can help make recommendations. One of the best things that I've heard recently in terms of clinical ethics and bioethics in general is if we can provide guidance at the very beginning before any type of ethical dilemmas can arise, we can mitigate it further downstream. And so there's a hospital nearby, one of the Harvard affiliate hospitals, where now they recognize that certain cases related to heart surgery were causing a lot of ethical dilemmas because usually it involved transplants, it involved a lot of family dynamics. And so they started doing something called a automatic trigger consult. So right when someone would enter into the chart, hey, this person is going to need a transplant or is going to be admitted to this unit, they would automatically consult ethics and they would be there right away. And they recognize that it really does work. And it's still, the studies are still, everything's still being researched. So we don't have concrete data on that. But once we do, I'll make sure I share it. Okay. I'm probably not going to be able to get through too many more of these, but I promise keep, keep these questions, these thoughts flowing and going, because I promise you, I will answer at some point, whether it's today or tomorrow. Okay. So the case of Miss Smith, I think we went through a lot of this really well. And so something else that I also want to discuss is bioethics does have 4 guiding principles. So we have respect for our autonomy, we have beneficence, we have non-maleficence, and then we also have justice. And so those are kind of the 4 merits at what we try to aim for. They do not go in a hierarchy. So you can't say, okay, well, we're respecting Miss Smith's autonomy, so like that's the only ethical principle we need to follow. You can't do that. You have to be able to discuss each aspect of that. And then you have to be able to interpret what that really means within the context of each case. And that's kind of how we've created a framework for looking at ethics. Because after all, a lot of times people in these clinical spaces, they are scientists, they're researchers, they're physicians. So they want to be able to have some type of systematic approach to these cases. But again, sometimes that systematic approach also includes bringing in that feeling of, okay, I have mixed feelings on this. This is feeling a little icky. I don't necessarily want to keep giving her morphine if I know it's going to inevitably cause her to die, but I also want Miss Smith to feel okay and feel comfortable. And that's something that we have to work with and we have to kind of dissect. So I wanted to come on to here and discuss a Paul Farmer quote. Does anyone know who Paul Farmer is? Hopefully. Maybe. Okay. I like that I have one. So Paul Farmer is someone that I am going to beg you all to look up after this call, in addition to Edmund Pellegrino. But Paul Farmer was a MD, PhD. He was trained here at Harvard, but he ended up working and creating something called Partners in Health. And he did a lot with global health, which is kind of the public health on a global lens, through a global lens. And he did a lot with just kind of the common good, being a good person and wanting to reduce human suffering. He believed that healthcare was a human right. Access to healthcare was a human right, is a human right, which is something that I very much align with. But this quote, for me, an area of moral clarity is you're in front of someone who is suffering. You have the tools at your disposal to alleviate that suffering or even eradicate it, and you act. And so he passed away a couple of years ago. He died one day. He had I want to say a heart attack. And everyone that I never got to meet him, but everyone that I've ever met that worked with him, talked with him, learned from him, say he is the embodiment of a virtuous physician, which is that exactly what I was talking about in the beginning. Someone that you strive to be, you want to be. When we are pursuing this path, I guess you could make it linear, but I think a lot of us have recognized that there's these branches that kind of come out of it, whether it be an interest in public health, an interest in figuring out how you can make a new healthcare system that is a little bit better and stronger than the ones that we currently have. So maybe you get into a business pursuit, or maybe a hospital administration pursuit, or maybe you are interested in how you can bridge the arts with medicine and how you can make patients who are sitting in hospital beds for weeks on end have a better experience through artistic endeavors. Whatever it is something that I am begging you all to hone in on and cherish. Don't let it die, because I know how hard this path is. I'm going through it, and it's tough. There are some days where I'm like, ooh, I did I make the right decision? I'm joking. We all made the right decision, but it's it's a path that can get very tough. So when you're going through it and you're starting to lose those things that you really love, make sure that you keep them there, and you bring them back out at times, and you figure out ways that you can still incorporate them into your goals, into your future, and let those random things that come up, those opportunities to be in an art show, those opportunities to take a business course, the opportunity to go shadow an ethicist, those type of opportunities are going to be what completely transform you and allow you to branch off and kind of create a more unique path that is real to your own identity. So with that said, I want to give some advice for my fellow humans here. Embrace those stories, right? Like, those are what make you you. And I can't even begin to tell you how many times I've done things that I'm like, what is this gonna, like, is this gonna help me in medicine, or is this gonna be part of my story? And it ends up being a life-changing moment. I want to give an analogy here. So, or I guess not an analogy, but more of a story. Right out of undergrad, I felt really lost. And I feel like that might be a universal trend. It just seems, I see all the girlies on TikTok talking about it, and it just, something about it, you feel a little lost because all of your friends are going in different places. You might not be where you thought you'd be. And it's a little distressing. And so my initial thought after undergrad was, I liked bioethics, and I was like, I want to do a master's in bioethics. Where can I do that? And I found Harvard. So I applied. My application was okay. It wasn't great. I ended up getting a big fat rejection. And something about me is when I put my eyes on something or I want to do something, I end up like really wanting, I go hardcore for it. So I told myself, I gave myself 24 hours to be sad about it. And I said, okay, the next day, after that 24 hours, that next day, I sat down and I made a plan. And I made this very robust 5-year plan on what I was going to do. I was like, I don't know what terminal degree I want, but in order to be an ethicist, I need a terminal degree. So I'll start pursuing it. I'll think about pursuing a terminal degree, but I'll start just doing as much as I can. I want to experience as much of life as I can. So I made sure that I was traveling, I was volunteering, I was doing all of this just to try to figure out what I really wanted. And I think that's really important to realize, because you can make a strategy, you can make a plan, but when you have these detours, they're the ones that bring you opportunities. They're the ones that give you those stories that you can eventually tell. And I think that's one of the most beautiful parts about life, is when you are ready to have these experiences and open to them, they kind of just appear sometimes. So I do believe in really soaking up these shadowing opportunities. In volunteering, I really like volunteering because it doesn't feel as much pressure as my normal job. And it's kind of fun sometimes. You end up meeting the most random people, and some of them will end up becoming your best friends, or you end up learning a life lesson. And networking is going to be optimal here. Okay. If you all do not have a LinkedIn already, I feel like most of you probably already do, but if you do not have a LinkedIn at this current moment, please start making your LinkedIn. I do post some LinkedIn tips on my page, not as much. I'll try to get better about that. But LinkedIn is going to be the best networking thing for you. Traveling as much as you can. One of my favorite ways to travel is, y'all, I wish I had a better mindset, but if I'm going to spend a lot of money, it needs to be like incorporated in my education and things like that. Like, I don't know why, but like I can't just travel for relaxation, which is a weird Zoe trait. But what I end up doing is I'll travel when I can go to a conference. So if I get invited to a conference, I'll pay money to go on the conference, or I'll try to get it paid for somehow. And then I'll tack on a couple of extra days to explore a new city or to travel a little bit within that adventure. And it ends up being really fun. So always keep that in mind, is when you have opportunities to travel for conferences, for medical school interviews, or things like that, try to make those adventures fun and exciting, and try to meet people out there while you're doing it. Working. I think working is great. As someone who worked during undergrad and then now in post-grad and in grad school, 100% am very grateful for my working environments. I learned probably the most I've ever learned through working, because a lot of it is you have a little bit of pressure from your bosses, from senior leadership, from your PIs. But it also makes you a much stronger person. And then asking questions. One of my favorite things is, for a long time, I kind of think I had this like know-it-all personality. And then something changed in me where I was like, why do you have to act that way? Like, you can just ask people, like, ask them for help, ask them how they got into their position. That's my favorite question to ask. If I am trying to network with someone and I don't know any of their research, or I really don't know them very well, I'll just say, why are you doing this? Like, what got you into this place? And like, what made you want this? And sometimes just asking people those very simple questions ends up sparking some of the best conversations. So keep that in mind. And then always question when things feel icky. I can promise you I started doing that every single day of my life. And I have more research questions than I have space on my notes app anymore. Prime example, I was scrolling through Instagram one day. We're going to talk about ethical dilemmas. We as a society have so many ethical dilemmas that we don't even recognize are ethical dilemmas. And I'm scrolling on Instagram one day, and I guess at one point I was looking up egg donation, and I was actually looking up postmortem sperm retrieval because I have a whole thing on that. But I must have gotten down the algorithm for egg donation, and I got offered $185,000 for my eggs, to donate my eggs through an ad target. And I was like, this feels a little icky to me, but I can't figure out why. So then I started diving deeper into it, and I was like, what makes me feel icky? Why? Like, and then I start asking myself, okay, it's not a respect for autonomy thing, because I put myself out there on the internet. I've kind of shared my privacy with them. I don't know if I love how we as a society have created this market, but then again, it's a free market. So then you start kind of going through and you start questioning your own thoughts, and that has created a huge research project for me, and it's something that I'm actively working on right now. But sometimes it's those kind of questions that happen in everyday life that might make you into that baby researcher, as I call myself, but it kind of gives you opportunity to look further and investigate. And then lastly, I want to end with probably the most important topic, striving for virtue. So strive to be a better person, a better student, a better listener, a better communicator, a better question asker, a better human. And I think that is just so important. And it's not that you have to do it every day. Guys, I was a little sassy with the pharmacist earlier, and I feel kind of bad about that, but like they were taking 10,000 years to fill my prescription. But I realized, okay, in that moment, I could have communicated that I had a deadline and that I needed this at a certain time. And that was on me. And that's something that I recognized right after. And I think every single day when we can have these realizations, these revelations, we can continue to better ourselves and then the people around us. You can talk to your friends about this and try to strive for virtue with them. And then in turn, they're going to maybe do it with their friends and their family. And we end up creating better humans together. So, with all of that said, that is kind of where I'm at. And I'm hopeful that you guys got something out of this session and enjoyed it. Please be sure to follow me, DM me, let me know if you have any questions, any thoughts.
Awesome.
Yeah, thanks, guys.
Thank you so much. Okay. So if everyone wouldn't mind doing a little virtual round of applause on Zoom, that would be much appreciated. We have time for, I think, a few questions today, and then otherwise we'll direct everyone to your social media and then ask if you're reaching out to Zoe, please be respectful. Don't spam her. If she takes a little while to get back to you, remember that there are 500 other people in this program, so she just might need a couple of days to see your message. But yeah, I think we have time for 2 or 3 questions today, and then we'll let you go.
So,
Okay, yeah, you're more than welcome to call on people that have their hands raised, or if you want us to moderate, that's also fine.
yeah, okay. I'm just gonna go in order of how I'm seeing it. So Maisha, I might
You pronounced my name right. Hi, first of all, you said that it's your first time doing this, but I think you were great at it, and I really enjoyed the session and knowing about your experiences. Your dedication to your work is truly inspiring, I must say that. And I'm so excited to have a speaker who is in the field of public health and is doing so much about it. So there's a lot of projects that I have done which relate to that particularly. And I wanted to get some suggestions on it. There's basically an infection detecting patch that works for chronic wounds and mainly targets low resource settings. So I want you to picture that kind of a place where people have a history of not, getting much medical attention. They are economically distressed, they might be not quite literate. And considering that scenario, what are some ethical and medical considerations that you think I should go on with? Because right now I just received some funding for it and recognition about it. So I thought I'd move on with the project, and you are an invaluable resource here. So I'd just like to know from you what I should go for.
Yeah, I think first off, thank you so much. You like literally just made my day. But I think a really cool approach that I've been trying to apply into a lot of my research, especially related around public health, is this idea of intergenerational justice. And so to kind of put it in plain language, intergenerational justice is where we can look at how can older generations work with younger generations to kind of bridge some of the gaps that are happening, because older generations, they have been dealing with this for a while, so maybe they have some remedies and methods, but then younger generations maybe have a little bit of knowledge when it comes to technology or utilizing communication strategies or being in the school setting. So they understand, okay, this is the lingo for how I need to talk to someone my age. So then that way they can work together a little bit more. Because I do think that that's a really great way to approach some of our societal issues. I think sometimes we're all so closed off that, okay, we can't talk to each other, we can't work together. And we see that within the science field too, and in public health and medicine in general. So that is something that I would definitely look into and see how you could apply some type of framework in that sense. But definitely message me because I have some other ideas that we can kind of dive deeper into.
Great, excellent. So there's many other projects as well. I have recently tried to integrate AI into telesurgery models, so I'd love to get your insight on that too. I'll be sure to reach out to you. Thank you so much. Have a great day.
Definitely. Bye. Um, do we have time for one more?
Yeah, we can do another one.
Okay. So I'm gonna pronounce your name wrong, but Raghid?
Okay, it's Ragad.
Rahad. Okay.
Okay, thank you for this amazing session. And I want to ask about how can I get into your position? Like, I want to get into Harvard Medical School. So I'm Egyptian and I'm not American to get into it after the high school directly. So how can I get into it?
Yeah, honestly, like I said the first time, like during the presentation, I got rejected the first time. I think I probably would have kept applying, but I also got into other programs. And I think something when you are looking at schools, I think sometimes the names definitely are there. And Harvard, I think, carries a very prestigious name. But I think also finding schools that fit you and what you value. For me, I went to the University of Virginia for undergrad. And to this day, I will tell you that is the best school on the planet. I love UVA. I want to go back there every weekend if I could. It feels like home. And I think that's something, one, to keep in mind. But two, when it comes to um, applying into some of these schools, I think networking is one of the most valuable tools that you can have. Right now, applying into M.D. PhD programs, they are very competitive and it's kind of scary. But something that I recognize in myself is I have networked more than I've ever networked in my entire life. And so I've gotten in front of just about every program director. They know my name now. So when they look at my application, they're either going to say no because I don't have a strong enough application, or they're going to say no because they don't have the funding. But they know me as a person. They know the value that I can bring to to the table. And so I think that's something that each and every one of you can do. And it really does make a difference. So sometimes it's about networking with the right people who can put you in the right spot. But sometimes it's about figuring out how you can get into a conference to get in front of some of these individuals, like maybe it's a dean of Harvard Medical School or a researcher here. But you guys are already in, I've already seen y'all already. So you have one connection. And if you're ever in Boston, we can hang out. We can go get coffee. I can take you on Saturdays. I can take people to the medical school and bring you all to the museum because Phineas Gage's head is there. So that's pretty cool. But yeah,
Okay, thank you so much.
of course.
Amazing. Thank you so, so much. Again, we really appreciate you taking the time to come and speak to us. And to everyone that wants Zoe's grad school tips Instagram, we will be sharing it at the end of the session and it's going to be posted in the schedule as well. But thank you so much again. It was a fantastic presentation and you have lots of thank yous in the chat as well.
Awesome. Thank you all so much. Really appreciate it. And I hope you all have a good rest of your day.
Thank you, you as well.
Bye, y'all.
Okay, perfect. So, Just to remind anyone that didn't see it in the chat, but we're not doing any Zoom polls today because we didn't do it in the morning session, so we want to keep it fair to all of you here as well. So Zoom is just automatically tracking your attendance here, so it's fine as long as you've joined with your full name. And now I'm gonna pass it over to Ahmad, who's gonna get started on his public health and epidemiology workshop.
Yeah, thank you so much, Davina. I hope everyone enjoyed that presentation. It's really cool that she's talking about bioethics because it's a really good segue into our workshop today, which is about public health. And part of public health also has elements of bioethics. So I thought it was very cool that those relate today. So give me just a second. I'm going to share my screen and make sure I'm going to be assessing the chat for questions. So feel free to send questions when I am giving a presentation and make sure everything is clear. So yeah, and quickly do that. Okay. All right. Let me know if everyone can see my screen. Okay, not yet. I think it's still loading on. Okay, great. Okay, y'all can see my presentation. Well, hi, I'm very excited to give this workshop again today on public health and epidemiology to just give some background. I'm a public health major, 4th year, entering UT on a pre-med track. And I'm really excited to say that one of the best decisions I made in undergrad was definitely choosing public health as my major. I can talk more about that towards the end of the session for those that are interested, just so we can go ahead and get started on the workshop material today. But yeah. All right, so a little bit different. So if you were a past participant, last year we focused a lot on definitions of public health. We focused on understanding some terminologies. We focused on looking at the history of public health, talk about the first disease that's been eradicated by public health measures. We talked about a lot of the history of public health. And I thought that would be really cool this year to share again. However, I thought it'd be even cooler to show you some actual work and some actual case studies that public health practitioners work on to hopefully spark your interest in some of these fields of public health, because public health is a very broad field. There's so many things, so many different elements and so many different categories of public health. So I really wanted to hopefully show you some elements of public health today and maybe spark some passion. So the goal of today's session is we want to understand the role of theory in public health and data interpretation in guiding public health programs and initiatives. So a lot of public health is focused on ensuring that you're using evidence-based science. That's in the definition of public health. So public health practitioners aren't just creating initiatives and programs without any sort of data backing it up. So a lot of that, where the data starts, is first grounded in theory. So first, it's focused on understanding the theories that affect health behavior, and then going and finding epidemiological data that supports that, and then going further and developing interventions and then evaluating interventions. So the first stop today we're going to have is to health theory. We're going to look into health theory, what health theory is, and then we're going to focus and do a case study in epidemiology. I sent out on Slack like a case study that you all could have read before today's session on a CDC outbreak of an influenza virus. I look forward for those that have read that just to engage in a conversation about that. It'd be really exciting. All right, so before we get started here, I want to know what everyone thinks of when they think of public health. What are some words that pop in your mind? I'll be looking at the chat, so. Global health, okay. Hospital, community advocacy. It's a very broad, correct. There's so many things that go into pandemics. Research, exactly. You can do research in public health, community hospital administration. Yeah, exactly. Health promotion. Those are all great answers. And that's exactly what public health is. So public health has so many different domains. One domain could be health theory, health policy, bioethics is a field of public health. Epidemiology is another field, environmental health, advocacy and awareness. So for those that are wanting to start somewhere in public health, there's so many different ways and different avenues that you can get involved in. You can do immunology, you can do prevention of disease, you can work on developing interventions that are rooted in evidence. So there's really something for everyone in public health. And a lot of time you might be very passionate about other subjects, but you can always have that public health lens. And that's why I think public health education is so important, because it not only allows you to develop cultural competence, it allows you to develop some skills in empathy and resilience. And we'll talk more about that today as well. So yeah, today's focus, we're focusing on looking into health theory and epidemiology, and we'll just go ahead and get started. So again, instead of focusing a lot on definitions today, I wanted to provide a case study. So this case study, this will make sense as we go through the examples, but I want to ground everyone. So today's area of public health concern for this topic, for health theory, is malaria. So for those that don't know, malaria is a flaviborne virus, and it's typically transmitted in tropical and subtropical areas. 94% of all cases occur in 2023 occur in Africa, and typically the global burden is shared just between 5 countries: Nigeria, Congo, Uganda, Ethiopia, and Mozambique. And 95% of global malaria deaths were noted in the African region. So when we're thinking of developing an intervention, or let's step back. When we're thinking of addressing a public health concern, most of us might think of going straight into developing possible interventions. What services can we provide? Can we increase the number of health practitioners? Can we increase the number of nets that are used to protect people against mosquitoes when they're sleeping? Look, what can we provide? So a lot of us, when we think of addressing a public health issue, we think straight into interpretation. However, most programs that focus on just going straight to implementation and not taking the time to understand the population, most of those programs are not successful, because you're not able to understand the different theories that are at play that are affecting someone's health behavior. A lot of places do have adequate resources. They do have the ability to, have preventative efforts in place. However, there might be other underlying factors that contribute to someone not engaging in a health behavior. And that's where public health theory comes in, is trying to understand those factors, and understand why someone might engage in a health behavior and what factors enable them or restrict them from engaging in a certain behavior. So you are a public health worker assessed to assign and understand a high incidence of malaria in an endemic region. So put yourself in these shoes. So as we continue along health theory. So health theory, again, it's pretty much a lot of different frameworks that help individuals understand and explain, as well as address health issues in different populations. So health theories typically can be at the individual level. So this focuses on why people make the health decisions that they do, and it looks inwards. Or theories can also be on the interpersonal level, and these would be theories that focus on social and external factors influencing someone doing or participating in a specific health decision. There are so many different theories under each of these different frames. If I had all the time in the world, I would love to go through multiple theories, but today we want to focus on 2 specific theories. At the individual level, we'll focus on the health belief model, and on the interpersonal level, we'll focus on social cognitive theory. There are other theories such as theory of planned behavior that can also fall in this realm. However, again, today we're just going to focus on these 2 specific theories. If you ever take a theory class in public health, you'll see the wide range of different theories that are used in public health practice. So the health belief model, the core construct of this is how, again, someone's personal beliefs about risks and benefits of a particular health action influence if they participate in a health behavior. And so again, there's a lot of different factors that go into play here. You'll have someone's perceived seriousness, perceived susceptibility, threat, someone's self-efficacy, someone's perceived benefits, perceived barriers, and we'll provide some examples on what this looks like. For example, in a malaria prevention case, for instance, the use of insecticide treating bed nets. And these are nets that help, again, prevent people, they go over someone's bed area when they're sleeping to prevent mosquito bites, which is the main vector that malaria is transmitted through. And okay, so part of this, we can go back to the model, the health belief model. So if we're trying to implement this intervention of using bed nets, we can focus first on understanding the different variables at play that would allow someone to make the decision of using a bed net if they had it, or if they don't if they don't want to use a bed net. So one of the core tenets of the health belief model is perceived susceptibility. And this, for example, this can look like, do people believe, or does someone believe that they are personally at risk for a health issue? This could be like, for instance, an example could be like, I think my children are at risk of getting malaria because we live near swamps. So someone believes that they're susceptible to a specific disease. So that informs their perceived threat, and that will allow them to engage in a specific health promoting behavior. Another tenet would be perceived severity, and that could be like, how deadly do you think this disease is? How deadly does someone think malaria is? So for instance, if someone believes that malaria is very deadly, they'll take more caution, which will they'll take more caution, which will allow them to engage in a health behavior. However, if they don't believe that, or there's some rumor, or there's something that they no longer believe in the threat of malaria, that might influence if their belief in the consequences of getting malaria are serious. And then another tenet of this could be the perceived benefits. So does perceived benefits include, for example, does someone believe that if they take the recommended action, that it will reduce their risk of malaria? So if I use a mosquito net, is it actually going to reduce my risk of getting malaria? That would be perceived benefit. And then perceived barriers would be something like what obstacles are at play that make a behavior difficult or less likely to occur. So for example, for example, if you're living in an area where it's already very, very hot, would you want to use a bed net? That could be a perceived barrier. Or for example, there might be other factors such as not having access to bed nets, or using bed nets that are broken or ineffective. Could be some examples of barriers at play that could influence whether or not someone uses the intervention of a bed net. So again, this is just one model, and this allows you to, again, take a step back and look at it through a lens of someone actually engaging in a health behavior. For instance, you might for sure be very cautious and use the bed net and use all the preventative measures, but that might not be the case for others. So the first step of a lot of public health studies is doing a social assessment, is to see what people believe in a community. And this will allow you to understand what people believe are threats, how susceptible someone thinks they are to a disease. And we'll see this again in the epidemiological case study that we will look at about these farm workers that don't even use protection against cows that have an illness. So that could, make you think, okay, for example, do they actually believe that they'll be getting infected if they don't wear these precautionary equipment to protect them? So again, it's all rooted in someone's belief, and this again is an individual level lens. All right, next. Okay, the next theory we'll look at is at an interpersonal level, and this theory is known as the social cognitive theory. And the social cognitive theory practically is, instead of focusing on your own beliefs of getting or being susceptible to a disease, it emphasizes learning and observing through others. So if, for example, if a family member or a friend is engaging in a health belief, that's going to influence whether you do it or you don't. So key construct of the social cognitive theory include like reciprocal determinism, behavioral capability. How capable do you think you are to do a specific health action? Observational learning. Again, we just talked about, if someone else is doing it, are you going to model that behavior? And then behavioral, like reciprocal determinism, would be again, the reciprocal determinism is the interaction between a person and environment and their behavior. So if you start using a bed net and that influences your friends to do it, That's an example of reciprocal determinism. Some other tenets within the social cognitive theory include like reinforcement, so positive, negative reinforcement, as well as like expectations. So for instance, if you believe that, if someone else believes and the belief gets to you, that influences whether or not you engage in a specific behavior or not. So that's kind of the lens through a social cognitive theory, what the social cognitive theory is. So I would love to see what if someone can, now that I've kind of explained what these theories are, I would love for someone who's heard this for the first time to try to explain what I just said. I would love to see it. I would love to hear from someone. Noah?
Can you hear me?
Yeah.
Right. So I think with a lot of the social factors, especially is kind of like societal pressures. I think we saw this the most during like COVID, where it would be like all of my friends, like take for instance, a big thing with masks. A lot of people at first didn't want to wear masks, and some people didn't see the reason of wearing masks. But a lot of people saw, oh, my friends are wearing masks, my parents, my family are wearing masks. I should probably do it too. Or
Exactly.
later on, when the vaccine was developed, a lot of people were getting the vaccine, or people were feeling iffy about getting it. People would realize that, well, I want to see my friends, all my friends are getting the vaccine and hanging out with each other. I should get it too.
You're right on point on that. A lot of the behavior that we do is through observational learning. So if we see other people doing it, we are more likely to engage in such behavior. So that's a great example of social cognitive theory. I'll take one more hand. Let me see. Or I don't see any more hands. So actually, I'll look into the chat. Okay, I don't think any. What?
I think someone has their hand up.
Camilla.
Well, I think that one of the things that we can give an example with, but I'm going more on like the personal level, is that well, you said that sometimes the factors on the society can impediment that someone uses a certain resource, and that happens a lot here in Mexico with a thing called dengue, that they tell people to use like long sleeved clothes, but it is really 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 hot, so they can't really use those long sleeved clothes without being uncomfortable.
Yeah, no, that exactly is why a lot of times when you're trying to develop an intervention, you typically think of an intervention that would best serve the most of the population, and you don't actually think of developing interventions that people are actually going to use. So again, when you think about theory, it's implementing all of those insights and factors and understandings into developing the interventions that you develop. And you summed it up great there. All right. We'll move on. Okay, great. So those are two theories in public health, the social cognitive theory and the health behavior model. The next theory is more of a model that is used to how we develop interventions. So when we look at this model here, the intervention or the implementation of intervention is phase 6. There are so many different factors that first go into developing an intervention, which include social assessment, epidemiological assessment, behavioral and environmental assessments, educational and ecological assessment, and then finally you'll get into whether or not you'll finally have the right lens to develop an appropriate intervention after you have gotten an understanding of all the other phases. So yeah, we'll go in and talk about each of these phases in depth now. So the social assessment is by far the most important, and it's by far the hardest sometimes for public health practitioners to practice. And this includes understanding the problem that's happening in a specific community. So when you think of this, you typically think that since you're the public health practitioner, that you are the expert in the field. You should know exactly what interventions are going to work, whether or not a specific theory is most applicable in this setting. However, take a step back. You need to utilize the population as the main source of understanding the health problem. And this can look like conducting focus groups or interviews with community members. For malaria, for example, this could be going to regions that have high incidences of malaria and talking to the individuals about their practices, and seeing what's working for them, as well as what's restricting them to practice preventative methods. And then after you've developed a good social assessment of the specific disease you're working on or specific intervention that you think might be helpful to implement, once you've talked to the population, you then go and try to find clinical data and surveys to identify at-risk groups. And again, the most important part of this is defining a specific population. Unfortunately, you cannot impact like the whole population. It's really hard to do with one specific intervention. So for instance, you would look for data that maybe, for example, pregnant women are more susceptible in this specific area to get malaria compared to the average individual. You would improve the risk, you would improve the average, you would utilize the improve the average approach here and utilize and develop an intervention specific to that population. So again, you cannot, like for instance, in a whole region with so many different people and so many different other factors that are influencing their health behavior, it's really hard to develop a macro level intervention. You really want to be very specific to a population that you're targeting. And again, this is utilizing epidemiology and clinical data and surveillance to identify these risk groups. And then the next factor to look into, the next assessment would be the behavioral and environmental factor. And this includes, for example, what behaviors are contributing and what environmental problems are contributing to malaria. So for instance, this could be people not sleeping under insecticide-treated nets regularly, or people are not using nets correctly, or people are delaying treatment after experiencing fever or malaria. This could be, this is how you would do a behavioral and environmental assessment to see what factors and how people are behaving in a specific population. For example, if people are not sleeping under these nets, and even when they're available, that tells you something, and that would be a question that you would want to further answer. And then you have your ecological and educational and ecological assessment. I want to go back here again. So phase one, we did the social assessment. You've done focus groups. Second, you developed a specific population at risk through clinical and environmental data. And then you've done a behavioral and environmental assessment. And this looks at specific behavioral factors that people are doing in your population and the specific lifestyle factors. And then you're on stage 4. And stage 4 is where you understand what are the predisposing factors, the reinforcing factors, and the enabling factors that are at play here. So predisposing factors would be factors that influence someone's internal motivations to make a person more or less likely to engage in health behavior. Reinforcing factors could be if you are factors that support or encourage behavior. So this could be like social rewards, feedback, or influences. And then enabling factors is what makes it easier or harder for someone to actually do a health action. These are like, for example, external conditions and resources. So for instance, if there's not a lot of bed nets to prevent mosquitoes from flying into someone's room at night, that could be something that could enable the spread of malaria. If there are only a few health workers to assess a large population that are susceptible to malaria, that's a specific enabling factor. And then predisposing factors could be that someone might not understand, what malaria is and how it spreads, or someone might not have a different belief system than yours, that malaria is caused by bad luck or just caused by weather, and it's not caused by like a mosquito transmission. So understanding that is actually very influential. And now I want to take a pause, and I actually want to recommend a book to you all. It's a book that I read a few years, like last year, and I think it's really informed how I look at cultural competence in a healthcare setting. And if you've read this book, feel free to let me know. I love talking about this book. It's one of my favorites. I'm gonna put it in the chat now. But this book, let me see where the chat is. It's not working now. Let me see where this chat. Okay, here it is. It's called The Spirit Catches You and You Fall Down. And it allows you to kind of understand these factors, the enabling and predisposing factors in a population, in fact, impacting someone's belief system on a specific disease. I don't want to like ruin the book for you all, so I'm not going to tell you all, like much about it. Besides the fact that it's a really helpful reading and it'll allow you to see healthcare in a very different lens. And I do think it's a really important book to read if you're going in the healthcare field. It's called The Spirit Catches You When You Fall Down. Okay, moving on. So we've done that, you've done all these assessments, and then you've understood the predisposing, enabling, and reinforcing factors. And then before you now are like, okay, now you understand that, for instance, if you're you've done an assessment and you understand that in a specific population, in a specific endemic region you're working in, there aren't enough people to teach people how to use these bed nets properly. Now that you've had this through doing the assessment, you'll now work on the next stage, which is a policy assessment or administrative assessment. And this is to see if there are any existing support systems already in place in a population. For example, if people are getting their information already through one avenue, maybe that specific health department isn't communicating it effectively. So instead of developing a whole new intervention or a whole new program, you'd want to work with these existing support networks, since you don't have to start from scratch. So that's what this next step is. So you have your idea, you have the specific problem that's enabling this behavior, and then you're going to do a policy assessment, and then you're finally at actually implementing a specific health behavior. So that's a lot. So there's again so many factors that go into play in developing a successful health intervention. And the goal of this workshop is not for you to develop your own health intervention right now. It's to just show you how important it is to work with the population that you're working with. I can't reiterate that enough. If you're developing health interventions, if you're wanting to improve specific health, if there's specific issues in public health that you want to address, it's really good. The first step in all before you do anything is doing social assessment and understanding the needs of the people that you're working with. And most of the time, it's not the specific needs that you envision them to have, and it's very important that you include them in ensuring that you're utilizing a social assessment that's representative of their needs. And a lot of time, it's also really, really important to have people, when you're developing these projects, from these populations working with you, and you not being the sole leader of this. So a lot of public health programs will have like steering committees, for example, where people from a population are actually helping develop the intervention. And it's not only you and your understanding developing, it's like you're working with the people to develop an intervention. And that can be really transformative in the success of your public health program that you're trying to implement. After you've done that, you'll then go to the proceed section. So you do the pre-seed and the proceed. We're not getting into the proceed model today, but the proceed model pretty much is evaluating the specific public health intervention that you've done and you've implemented. And this includes impact evaluation, outcome evaluation, and process evaluation. But that's kind of the step of getting a really successful intervention in place and the specific tenets that it includes. All right. Okay. So now I want to challenge you all to your own question. So you're a public health worker assigned to assess and understand the high incidence of malaria in an endemic region. And here's what you know: that 2 in 5 households report at least one malaria case per month. Only 25% of families use bed nets regularly. So that's low, and the people aren't using bed nets. Clinics are understaffed and often lack rapid diagnostic tests. And many community members believe malaria is caused by cold weather and curses. And the question I have for you all, again, that was just the background. So now you have your background information, and now you've done an assessment. And this is once you've worked with the population, this is the assessment that you've come to. So after doing assessment, the assessment shows that many people don't believe malaria is life-threatening. So that's a predisposing factor. You can go back to theory to understand that question development. And then the next important piece is that community leaders have strong influence, but they're not involved in malaria prevention. So based on the proceed model, which of the following would be the most appropriate interventions to improve malaria prevention in this community? So I'll go back. So this is what you know. So if you just wanted to develop an intervention with this specific information, just what you know based on data, your first clue would be, oh my God, 25% of families are using bed nets regularly. That's a really low incidence. Let's go and provide 4 bed nets. That might be your first initial, if you did not, first initial possible program to develop or possible need to assess. However, if you, again, you do your social assessment, you figure out that actually many people do not believe that that malaria is life-threatening. So that will probably lead to them not actually using the bed nets, even if they're available. And then you also realize that community leaders have a strong influence, but they're not involved in public health prevention. This should shape the intervention that you choose on the next slide. So I'll read the question out again. Based on that model, which of the following would be the most appropriate intervention to improve malaria prevention in this community? So would it be A, distribute additional free insecticide-free bed nets to every household? Would you launch a mass radio campaign, and or would you train community leaders to promote correct bed net use and educate the public on the dangers of malaria? Or would you build a new health clinic in the center of the village to improve treatment access? So
We
now
have some people with their hands raised too. Oh, sorry to interrupt.
Oh, hello.
Oh, I was just saying that we have some people's with hand raised in case you didn't see that, but sorry to interrupt.
Yeah. I'll take again, if I pronounce your name wrong, please let me know. Doris? She's like, I don't think we can hear you. I'll go to the next person. Feel free to just type your answer in the chat or the discussion. Mara?
I would say C.
And why do you think C?
Because most families might not be using the bed nets because they don't know how to use them. And they also, a lot of them don't know that malaria is something predisposed. So that also might be why.
Okay. Great answer. That is the correct answer, but I wanna target the specific. I want to see what other people are thinking about what led to their answer. So C is correct. Great job, everyone. But I want to see what everyone else is thinking.
Can you hear me?
Yeah. Oh, Doris, yes.
Okay, perfect. Yeah, so I would say C, because obviously like the bed nets are like available, but the issue is that people are kind of like uneducated. So having like leaders being able to educate the public would be the best like thing to do to combat the issue.
Perfect. One of the key, after you've conducted your need assessment, this is what's driving this intervention is community leaders have strong influences on people's decision making, but they're not involved in malaria prevention. So the first thing you'd want to do is try to see if these community leaders can get involved in helping, improve malaria prevention in this community. So yeah, does anyone have any rebuttals? Does anyone have another answer choice that they think is more fit than the answer choice C? Adam?
I mean, I strongly believe that B would also be a very proper solution. Furthermore, I strongly believe maybe you can try educating the youth in their high school or let's say middle school. I feel like by identifying the issue from its core, we could solve this. Furthermore, community leaders will no matter what they're gonna still be okay. So we're being told by our governments to do so, and we strongly believe it's manipulation. And I find that this issue is very evident in community that are very far right or extremely Christian who claim to be religious. So community leaders aren't a viable option. So mass radio campaigns or just educating the youth would be the most viable options. Furthermore, by creating health clinics that are available, such as InterD, I strongly believe it will help as long as people know when to go there and understand the danger of malaria if they learn about malaria as a whole in, let's say, middle school or high school.
I think that's a great answer. I wanted to, however, backtrack a little bit on that. So again, when you're developing these interventions, you do not want to have your own personal beliefs of what you think the best intervention is going to be influencing what intervention that you put out to the specific community. It should always be what the community is needing. So if we are doing community needs assessment and the data that we have is that people aren't believing that malaria is threatening, however, people do believe in their community leaders, no matter, if there are other factors at play, like, corruption or anything, but people have Europe's trying to assess malaria here. And based on this needs assessment that community leaders believe, that people believe in community leaders, you'd want your intervention focused on assessing that. Yes, high school flyers involving the high school would be great. But again, if that's not what your need assessment shows, or that's not what the population that you're working with that's not what they need, then that will not be a good intervention, because then people might not, it will likely not, it will likely not result in any outcomes that can prevent malaria, So
Sure. However, like others, including myself, would strongly argue that, like, if in the case of like communities such as the one you're giving in this example, community leader, after let's say I'm like a scientist who's in public health and I'm trying to discuss with them and like, hey, we got to target this and that, they're going to be like, the moment they go into like their church or to like a town meeting, like the next week, they're going to be like, our governments are trying to force us to do this and that. Like, for instance, look at MAGA societies and like communities. I find that the moment we ask them to like, hey guys, remind you to take your vaccines, we find the community leaders going into their town meetings. Our governments are forcing us to give our children vaccines. That's when we give them autism and like just a lot of like bullshit. I'm like sorry for like the language, but like that's basically what it is. So don't you think like community leaders could backfire?
I would love to have a conversation with you towards the end of the session about that. I think you have some really great points, and yeah, feel free to like stay up after the session today and we can discuss that. But again, the main point I want to get across is when you're trying to develop interventions, you need to focus on what the community needs and not what you personally believe a community needs. That's kind of the main takeaway from this question is, yes, C would be the right answer. People believe in their communities, people believe in their community leaders, but they're not involved in malaria prevention. So that will be your first step. Now, it might not be the most, it might not lead to the outcome that you are hoping to see in this specific population, but it's what's rooted in the needs assessment. Again, I can stay on after the call to further explain this and engage in other conversations around this topic. But yeah, so that is, again, an example of how you utilize PROCEED model in developing health interventions for a specific population. All right, so we're going to now move on to our section on epidemiology, which is concerned with the distribution and epidemiology is related to the distribution and different factors that help I'm going to restart on that. Epidemiology is how the disease is distributed amongst a specific population, and epidemiologists focus on determining specific factors that influence disease and how it's spread across specific populations. So this, again, we're going to use some of the case studies that you hopefully had read before today's session. So I want you to put yourself in the shoes of a public health worker. So imagine you're a public health officer working in a county, and you get a call that there are sporadic infections of highly pathogenic influenza HPA1H5 virus that's been detected among dairy farm workers in the United States. So here's some context. So H5 viruses have circulated globally among animals since 1997, and with sporadic human infections. However, in March 2024, in Texas, there was actually a new clade that affected in American dairy cows, in US dairy cows, and this is a new animal reservoir. And the first human case from this outbreak was a Texas dairy farm worker in April 2024. And this led to enhanced surveillance of dairy herds and poultry facilities in the US. And now you're a public health practitioner and you you get the situational report about this outbreak, and now you are gonna go. You're a field epidemiologist, and you're gonna go and you're actually gonna go and interview some of these dairy farm workers and try to understand what led to this outbreak, what factors that we could possibly implement to prevent such further outbreaks. So you're gonna go to Texas from wherever you are. You're gonna fly over to Texas, and you're going to start developing some interventions. So, as a field epidemiologist, what do y'all think the first step will be? Would the first step would be to develop specific interventions to prevent further outbreaks, or would it be to assess the needs of the community and seeing what factors are contributing to the spread of the infection? Exactly. See what factors are contributing to the specific that are contributing to the disease, the increased incidence of these infections. All right, so now I'm actually going to show y'all an example of a real questionnaire that I actually developed to show y'all how a specific questionnaire could look like for this specific outbreak. I'm going to go ahead and share my screen to actually walk through how a real questionnaire would look like. So if you were in the field and you're wanting to go and surveil a population that has this outbreak, what it would look like. So I'm going to go ahead and share my screen. And all right, so first of all, you are now in this specific area that in this specific dairy farm, and you've found a few people that are representative in the dairy farm that are wanting to provide some answers and participate in your questionnaire. The first question, again, you would want to ask is, the first question you typically ask is based on a case definition. So for instance, if there was an outbreak between a specific time period and you want to assess people, you want to assess those specific people, you'd want to ask, first to make sure that you're talking to the right people. So for example, in this outbreak, they wanted to assess people that had worked within 90 days at a specific dairy farm. So you first ask that, and another part of the case definition is that they worked with a cow herd that had a laboratory confirmed infection of bird flu. So that's the first question you'd ask. And you'd usually want to have 3 specific answer choices: yes, no, or not sure. And typically, if someone answered that they haven't worked in this farm at this specific dairy farm, or haven't worked with cows that were infected, you'd want to end the interview there, because their data is not going to be helpful for you to assess what's specifically going on in this specific outbreak. And then you would look into other factors that might have influenced the disease. So for instance, one of the factors here was taking the seasonal influenza vaccine, protecting against this specific outbreak. So you could ask that question. And typically, again, you want to have multiple choice answer choices. You want to have multiple choice answer choices and not free response answer choices, because you want to be able to take this data and put it onto a data sheet, which I'll show you all in a second. So you can take this data and put it onto a graph and table to actually understand what's going on. So if you have a lot of data that's, for example, in short answer format, it's going to be very hard to put that onto a table, and put it onto a graph. And a lot of times it's really hard to understand what different people's perspectives are. So they may not be giving you the same information if you had used a multiple choice questionnaire instead. So typically these questionnaires are done in multiple choice formatting. And then here, one of the factors influencing was the different job tasks performed. So you would provide a checkbox list of the different tasks that have been associated with working with the cows. So you would just provide a checklist answer now, because a lot of times that there might be more than one specific, people might be engaging in more than one specific job task. So you want to assess all of that. And one of the things, as I was giving this presentation in the morning, I realized is that a lot of times you might not remember that you bred cows or that you fed cows. So to make this questionnaire even better, it was to have a similar format, like, yes, I bred cows, or I don't remember, or I don't want to answer, or so that it ensures that people aren't just guessing or just giving an answer choice. And then you can also other factors that were influencing would be not using PPE. So for example, using an apron, gloves, all of those could be in a specific checkboxless answer choice format that you can assess when you put the data on a table. So again, similar here as well. So here, again, the main kind of takeaway from this is when you're developing specific questionnaires that you really want to ensure that you're able to assess a wide range of different answer choices. So you want to use checkbox lists. You don't want to use short answer formatting. That's again the main takeaway from this. And now that you've had this specific, now that you've had this data, you can again easily put this onto an Excel sheet and analyze it. So that's going to be the next step we'll do. So I'll stop my sharing my screen and I'll share my main screen back again. Okay, here you go. All right, now that you've had you've taken this data and again, if you read the case study, you would have seen exactly where I pulled this data from. Again, I would have loved to give you all how to create this actual table or how to create this actual figure based on the guidelines of the CDC. However, it would have taken too much time, and I feel like it just would have been really difficult to understand. So I decided just to create the table for you all. So from this table, again, this is a question that you asked during the questionnaire about what job tasks led to increased incidence of this infection. And what we notice here is that over 100 people that were seropositive, that means that they had antibodies for this virus, they were cleaning and milking the parlor. And once you put it on a table, you can easily tell which specific job duties led to people having a higher incidence of infection. So based on reading this table, based on reading this figure, what can y'all tell me? So I'll take some hands. So if you read this table, if you just looked, if you can see, I hope you can see my screen. Noah?
You hear me?
Yes.
Yeah, it's kind of hard to read, but I read it earlier. So you see that a lot of the situations where people are getting antibodies for the flu are being getting infected or getting antibodies for it are in situations where they're in direct contact with the milk, with the liquids, or cleaning it up.
Yes.
And after reading it earlier, you would expect that in these situations they'd be using a lot of protective gear, but in a lot of situations they weren't, which is how you end up with such a high rate of transmission.
Exactly. And based on looking at this table, you can see that the specific job tasks that led to higher incidence of this infection was milking cows and cleaning the milking parlor. Great job. So yeah, Maisha.
Yeah, so it's largely the exact same thing. It's kind of tough to read here, but I saw it earlier. So we can see the largest proportion of contributors, people who are getting affected by it, are those who are in direct contact with the milk. And this helps us get a clearer picture of why this might be happening. We know that they may not be well educated on PPE, the use of PPE kits, use of protective gear. And on basis of that, we can also build the proceed part of it more effectively.
Exactly. Great answer choice. All right, so exactly. So now you've taken this data and you understand that you've taken this data, and the conclusion the data has led you to is that 100% of people that were cleaning the milking parlor had this incidence of this infection. And then you can go in further and understand those specific people. Now that you've understood, now that you find that data point, you can go and interview these 8 people. And one of the data points that were provided in the article was that all 8 of these people with the infection were Spanish speakers, and all did not use specific protective equipment such as respiratory protection and recommended eye protection. So now this can ground the specific intervention that you'd want to implement in this specific population and can ground your public health study. So yeah, that's a lot. It's again all rooted in the questionnaire. So if you did not have a good questionnaire, if you did not get those data points that you were supposed to, you would have not come up with the conclusion. That's why it's so important that when you're developing questionnaires, that you're utilizing the population, that you're actually trying to that you're utilizing the population and focusing on the needs and doing that social assessment. Yeah, so the question I want to ask to kind of conclude the presentation is what would be the next step based on this data that you would possibly want to implement? What public health preventive program that you would want to implement to prevent further disease transmission? I'll pick on someone I haven't called on yet today. Mara?
I would say like amplify the importance of using respiratory protection and eye protection and such.
Exactly. What if in this specific population that they're working in areas that's really hot? For example, you want to emphasize that specific intervention that utilize PPE. But what these protective equipment, if you've ever been in some of these, I have, it gets so hot so quick. And if you're already standing in Texas weather where 100 degrees is just like a normal average day, it's going to be very hot. So what's a more specific intervention that you could possibly do? This can be a question for anyone, or Mara, if you want to re-answer, feel free to. Diego?
Yeah, so one of the things I noticed that it said was that all 8 of them that were ill were Spanish speakers. So not only would I want to have programs and maybe prevent things like maybe masks or something to try to help, like limited protection, like you don't have to put on full PPE considering the heat, especially if there's no ACs around. But I would also say that having it spoken in are you speaking? I cannot hear anything.
Oh yeah, no, I'm saying like you could possibly encourage the managers of these farms to increase the amount of breaks that people are, or the amount of hours that they're in PPE. So maybe every 30 minutes they get like a break or something, Those are the specific interventions that would be successful,
Yeah, I was also going to say that they should give like an emphasis on giving the instructions in multiple languages, especially in Spanish, considering people who are infected. Sorry about
Exactly.
that.
Yeah, no, that's perfect. That's a perfect way, possible public health intervention that you could implement in this population. So yeah, that concludes the end of the workshop. I know there might be more questions. I'm going to look at the chat. But Davina, I know it's almost 5 minutes before the end of the presentation. I want to hand it off to you to talk about the workshop the next Tuesday.
Yes. So for everyone that saw my message in the announcements channel about the pre-med, cold email template, research opportunities, workshop that is very optional. You don't have to attend. That will be happening next Tuesday at 5 p.m. Eastern Standard Time. We just picked the time based off of what the most people were available for. So the majority of you selected next Tuesday at 5 p.m. Eastern Standard Time. It'll be about an hour or an hour and a half on Zoom because we also want to leave time to answer all of your questions. So we will be covering what a good cold email looks like, how to find medical shadowing and research opportunities in your area, and also just answer your questions because we've noticed that throughout the sessions, a lot of you have questions for our guest speaker about, what to do in high school and how to prepare yourself. So we thought we might be able to tackle some of those questions ourselves as well. And the Zoom link for that will be posted on Sunday. The session will be at Tuesday. Again, it is not mandatory, so you do not have to attend. There's no pressure. We just want to be able to kind of help guide you through what is sometimes a very overwhelming process. So if you'd like to attend, you can, but you do not have to. Okay.
Thank you.
And I think that is it for today's session. Again, there are no polls, so you are more than welcome to head out. And thank you so much for joining us for our first week of our summer program. We are super excited to have concluded week 1. And we will see you back next week on Monday for our final week of the program. We can't believe it's already half over because we kind of feel like we're just getting to know you and getting to interact with you. So it's been lots of fun, and we're very excited to see you back next week. But otherwise, I hope you have a fantastic rest of your weekend, and I will see you back here next Monday. Ahmad, feel free to stop the live stream, and if you want to take questions about your workshop, feel free.
Yeah, for sure. Yeah. So if anyone has questions, either reach out to me on Slack, or stay after the call today, and we can talk. I'll stop the live stream.
I see some people that have their hands up too. They might have questions for you.
Give me one second. I'm trying to end this.